addressing you all, in public. I am not used to in general. I don't know why I'm going to be. A very, very special day for all of us. I'm very, very happy to see you all here, and you're also connecting with your old friends, sharing your memories and everything. Very special welcome to Dr. Anand Raju. We are really honored, sir, that you're here. Looking forward to, I know so much of hard work you all put, especially with Dr. Ramesh, strict, what I say. Yeah, good teacher. Then you say good problem, no? He's a good problem for all of us. So. Yeah. So that's what. See, I don't have anything to say other than, I'm really happy and very, very warm welcome. And now I will ask Dr. Vasant, the chief mentor of this course, to address you all. I hope he doesn't talk anything about occlusion today.
Good morning, my dear friends, and Dr. Anand Raju. You're also a friend, so I need not segregate that, okay? Today is a very special day, not just because it marks the culmination of a demanding, deeply enriching year, right? But because it gives us a chance to look back and appreciate the journey we're taking together. Now, even though only happiness should be in my heart now, there is a small sadness. The realization that this association might end today. So I'm going to place a demanding request, okay? It's a demanding request, right? Please hold my hand now for guidance, and please continue doing it later out of love. Okay? This is a demand from you. Now you hold my hand for guidance as long as you want. When it ends, continue doing that for love. Clear? I will welcome it. I want it. Okay? This symposium is not merely a showcase of cases, right? It's a celebration of growth. In every case you're going to present now, I won't see the finish or anything else. I see your late nights, the efforts you put in, and the sincerity, and the persistence. So don't worry about the case finish you're going to show. It shows your dedication here. It sort of teaches you and makes your life more balanced, how you balance your family, your practice, and your learning with grit and patience. I can see there Sabbeena sitting with a child. So every one of you, your mothers and fathers, I know how much a sacrifice you have to do to balance all those stuff without compromising that, same time learning here with us. And what we teach is not something that you just read and put it down, right? It has to be little lived in the practice. I really admire you all for that. You are succeeding in that. I'm saying succeeding, not succeeded, okay? In succeeding in that, okay? So make a note of that. Succeeding in that, not succeeded in that. Keep succeeding. When will you succeed? I don't know. Don't stop. Do that. That's one thing you do for me. Never stop learning. There's no point in time you can say, I've learned everything. Clear? Now, I'm sure that you have held on and will hold on to one thing that matters as I'm concerned. You will learn dentistry or not, I don't care. But you should emerge as with goodness, a good human being. I keep saying that every time. Once you are a good human being, you will learn automatically. Because then you realize responsibility. When you treat a patient, you have to be a good person. Otherwise, all you learn won't be useful. Not to you. You may learn money, but for the society, for the patients you treat. Okay? Keep that in mind always. That's more important for me than anything else. The goodness that shows up when no one is watching. Right? You can't be good because I'm watching, you act good. No. Goodness that comes when no one is watching. The goodness that makes you do the right thing to the patient when no one is judging. The goodness that doesn't require a spotlight. Only sincerity. Okay? This academy is not to manufacture stars. We are going to say, put in a thing, say, these can all, got this degree. No. We want to nurture good doctors who are good human beings first. Doctors who act kind with integrity. Okay? For this, I want a promise. You'll attempt. No one succeeds in this. If you ask me, I'm a good man, I can't say. I attempt to be a good man. Right? The success, others will tell you. You will never know. Okay? Keep striving for that. And if you do that, what I aimed for, I'm happy that I can see that come in front of my eyes. Okay? Now, before I finish, Dr. Ramesh and Dr. Malar, I don't know how to express I don't know what word it is, because I had dreams. Now, sometimes dreams can't be expressed without people support you for that. Sharing a dream becomes the best thing, because now we have a team to share a common dream. My dream of bringing occlusion to many doctors, not just to do a better treatment, but to become a better dentist, is coming true because of Ramesh and Malar. It so happens they're almost like my children's age. So I've gained 2 more children. Right? I'm saying I'm not lip talking. You understand? And then I hope I get many more here. Okay? That's what I want. So Ramesh asked me to tell my short life story, not life story, dental story. See, I started my practice almost 45 years before, 1980. Okay? Many weren't born, I think. Or maybe toddlers then. Okay? I passed out from the dental wing of the Madras Medical College. It wasn't a dental college then. Now, when I passed out, like any student we pass out, I was on cloud 9. I thought I knew everything in dentistry. I even thought, why 4 years, 5 years for dentistry? Now I understand. Even for occlusion, you need that kind of a time. Understand? Now that humility came only after 10 years. For 10 years, I was walking as if, right, I'm the master. Everything in dentistry I know. Then, when reality struck, that I know nothing, then my education started. Till then, I was, uneducated, technically speaking. Okay, thinking as if I know everything. If you don't know anything, you think you know everything. The moment you start knowing, then you realize you don't know so many things. Anything you learn opens more questions. More answers will be needed. That happens everywhere. I hope that happens in your thing also. That will make you go up. Okay? Now, after 10 years, my first thing was in endodontics. Realizing that I can't do endo, I opened Grossman again. Extracted teeth in a bucket, doing everything. And then my teaching career started with endodontics. I had workshops in endodontics for almost 7-8 years or even more. Then composite. Frankly speaking, they say mother of invention, need is a mother of invention, right? Now, when I passed out, no composite. Black's cavity, right? So to unlearn Black's cavity was very tough. For you, that problem wasn't there. You have other things to unlearn, right? So I knew I had no knowledge on composite. So I had to learn composite. From whom? From nobody, right? So I learned composite. And one advice, when you learn something, please teach. That makes you understand the topic much better, right? So I had composite courses about the bonding, the fourth generation bonding, all those stuff I learned, and then I taught. Once I started teaching, the students make me learn more. It becomes a sort of spiraling up cycle. So that was my second course, was composite. Then a very major change happened in my career. I always say, if you want to separate my career in 2 compartments, one was before POS and after POS, right? That orthodontic knowledge made me think as a patient as a whole. not a molar walking in, a canine walking in. You understand what I mean, right? I saw the whole face in front of me and not individual teeth coming to me with problems. So that holistic approach made a lot of changes in the way I look at patients, look at treatment. So orthodontics, I felt, was a game changer in my knowledge cycle. So once I knew orthodontics, I started looking at patients, a whole treatment plan came in. Till it was planning for endo, planning for a flap surgery, it never planning for the patient. You understand what I mean? So I saw the face, I saw the profile, I saw everything I saw now, a patient as a whole. Then, some article I read, I think it was Jean McCoy, Dental Compression Syndrome. So that made me think about occlusion, where he talks about class A abstractions and other stuff. Then, once I started into that, I was wondering what to buy as an articulator. Then Vijay Dental opened up the BPS. He said, we sell an articulator, a face bow, and then I know Vijay Dental always supports me behind. So it was no brainer for me. I went into BPS for buying an articulator. So I bought the articulator, Stratos, and then at that point again, as usual, I was left in the lurch, no one to teach me BPS. So I was forced to. The need always makes you do things. So I had to learn BPS, go through the net, browsing on occlusion and every topics of setting teeth and all. I stumbled into the occlusion we know now. Somewhere near 2007 or 8 or 9. Then my occlusion journey started. In the meantime, I did courses on cast posts and root posts, cast partial denture, correct? So I was doing all this, and I was ortho also as an instructor for the POS for about 7-8 years. Once I entered into occlusion, everything stopped. I was literally immersed in occlusion. I used to be an avid reader. I read a lot of other books, not dental, so many other books I read. Everything almost came to a standstill, and everything I read was occlusion. I was dreaming, breathing, eating occlusion. You know that. For almost first 15-20 years, last 15-20 years. Now I decided to go back, start taking other books and start reading now. Because I need to do that also. Okay, so this is my dental cycle, life cycle. Now I am a complete passionate on occlusion and orthodontics. Even that was like that. The moment I went into ortho, in a dream I'll only dream torque and values there. So that's how I love the topic. Now I started realizing I love teaching also. You'll find me full of revved up, with full my endorphins all flowing at the end of the class when I should have been tired by then. Okay, so I love that because you made me love it.
It's reverse as well.
Okay, so if I can transmit some of this into you, my life's purpose is done. I mean, I don't expect anything much in life. I know my philosophy is different, all of you know that. I live a good life. As far as I don't know that I had a good life at all. I try to live a good life, and at the end of it, I happily retire at some point of time, maybe. I don't know. Don't make me retire, okay? Don't make me retire, okay? With that, I think I'll stop here, and I want Anand Raju. See how humble he is. He won't know. He's the director of Vishnu Dental College. Please give him one. I want him to say a few words here. A few words here. Come, sir. No, see, respect doesn't need age. So I have great respect for this person here. Okay? So please.
So, very good morning to all of you. I think I cannot express my gratitude to my teachers, and Dr. Vasanth sir has played I think my journey in occlusion also started with his course. I think it's 2016-17. It was a 3-day course. Again, very similar to his journey, I wanted to buy an articulator. I didn't know what articulator to buy. Being an orthodontist, practicing almost for 18-19 years, probably because not being an orthodontist, but being a general dentist, I realized that so many areas have been not covered well, and I felt probably somewhere I'm missing for my patients. And that led to the journey of occlusion. And as again his journey started, Manoj is a very good friend, and then he said, sir, why don't you attend his program? It's a good program, he's a good teacher. And I took his program in 2016. So that was the foundation for my, I would say, occlusion learning way back in 9 years back. And I usually, every time I always sit in the front. That's why today I thought being when sir said, why don't you come for the symposium, I was very happy that he invited me. I didn't expect that he'll invite me. But 2016, after I started learning, then I also went slightly ahead. And then I said, since we are a part of a dental school, I thought this is something which is not taught in our BDS training or an MDS training. And I said, sir, how do we introduce this into a college? Many times we called each other, probably sir was busy with his workshops, I was also busy with other things, and then during COVID we had more time. So we used to have some conversations, and then I said, sir, why don't you develop a curriculum for dental schools? But who is going to teach? Then I said, sir, I think the only way is we have to first have an internal team in the college who can probably teach the students. It's not possible that, every time you have to come in and teach for a day or two and go. And he readily agreed. He said that is the right way of doing it. I think we have to develop a team at the college. And what you have undergone for the last 1 year, the same thing, sir. I mean, that is the greatness of him. He used to come to Vishnu at Bhimvaram, and almost the same program he conducted for our about 25 dedicated faculty who showed interest in occlusion. So we picked up faculty from all the specialities. We didn't think that it was a prosthodontic discipline or an orthodontic discipline. So faculty from oral medicine to oral pathology to every other specialty was a part of the team. And 1 year we had a very good program. Dr. Ramesh, as always, inspiring. He inspired a lot of our faculty. And it's been about a year the program got over. Last week, I would say last month, the team at Vishnu Dental College, they started a program for the undergrads and the postgrads. It's called VOICE. It's Vishnu Occlusal Integrated Curriculum for Enhanced Learning. So we didn't want to copy the same thing, but then we thought, let us develop a curriculum for undergraduate learning. And I think occlusion is the foundation for dentistry. And if we don't know occlusion, I think at some point in our lives, we will learn. And probably if someone has not learned it, then I think we are not complete dentists. And I firmly believe this is where we have to start. And I cannot express my words for Sir and Ramesh for all the hard work they have put in. And every time listening to them is always inspiring for us. So all the webinars, all our faculty attend, that shows how they can get the audience coming back to them again and again. And the concept of occlusion is quite, I wouldn't say it's complex, but it needs a lot of reinforcements, it needs a lot of practice. And unless you keep practicing more and more, you will not come up with new queries. So I think that is where it is. And I have seen people with different age groups. I think if you can start it early enough, that's the best, because I think you will probably in 10 years or 12 years or 15 years of your practice with occlusion-based dentistry, I think you will do much more for your patients than, I think, non-occlusion driven dentistry. So thank you, sir, once again for being here. And I mean, for inviting me to come and be a part of the program. I thought, I think it's thank you, Ramesh. Thank you once again. Sir. So I am a big fan of sir. So, I mean, there's a lot of learning from him. And as I told you, my foundation started with him. So I cannot express my gratitude towards him. Thank you once again, sir.
Okay, good morning. I'm not going to waste time. So we have very less time because it started with 5 presentations, then it became 10. As days come by, 15 presentations. Yesterday night, it became 22 presentations. Okay, that is a huge achievement because whenever we attend a course, after the course is over, we can't even reach a mentor. That's the pain point what I had in my entire career. Okay, so I cannot reach out to the mentors to ask a doubt. I cannot reach out to anyone. So that's a straight opposite what I got from sir. That's why I'm here as a mentor next to a legend in occlusion. We fondly call him Dawson of India. So I hope that word, my friend Jay, he used to call always, yes sir, you are Dawson of India. That's why he introduced me to this great subject and great man. So I have to thank, next to God, I thank Dr. Jay Karan for introducing me to this world. Okay, so there is no talk, no present. All we have, we have stopped all our presentation after seeing the list. That's why we couldn't even check who is there in second and third batch. Some of them we have put here and there, but it's okay. We are a family, right? So we are a family, right? Of course you accept, right? Sir? He was a huge number for presentation. Seriously, they are here for till 12:30, 1 o'clock. They are here, sir, checking all their presentations. So it was a very nice feeling to see, because end of the day, we have made almost 50 or 60 FMRs done in a course, which is a huge achievement for Vasanth Dental Academy. Okay, so we are going to start our first presentation. So officially we are starting. So please stick to time. Again, you will call me teacher, school teacher, but what to do? That responsibility is given to me, so I have to do it. Yeah, it'll be. No, we are adding. So please, because I don't want any of you to miss this opportunity to present. So that's the aim. If you're going to encroach more than a minute, you're going to encroach into the. We are planning to have a buzzer, but it'll be you'll be tense to do that, because anything, I feel like 10 minutes is a very good time to convey what you wanted to convey. If you are thorough about the case, it's nothing. So as part of family, we welcome you again. We're going to start the presentations straight away. In between, we'll have, there is no particular order which I'm giving. I'm just mixing the cases so that you have a flavor of all the cases. That's all. So no, I have to call them first, second, nothing like that. I just decided, okay. So we are starting with one person where I know from where she started. Okay. So I won't talk about everyone, but we don't have time. One word, if I have to say, from zero knowledge on occlusion to this level, it's a proud moment for Vasanth Dental Academy. And there are, every batch as those people. The first batch is, we call them as the pioneer batch of, because they believed, no, they just saw the curriculum, they booked. I don't know why they booked. I don't know what faith they had. That too, before announcing, one person, she started transferring the amount and she was ready. She don't even know where she is jumping into. Dr. Shanmugapuria. Thank you, ma. So starting that journey, she is the first one to start that. She gave us faith. Okay, so I'm not going to waste time. I'm going to call Dr. Divya from batch 1 to start her first presentation in the ODD Symposium. Give a good round of applause.
I'm Divya, basically a pediatric dentist, now a proud stomatognathik specialist. It's a privilege for me to present my case on this honorable dais. This slide I dedicate to each and every one present in this room. We all took that road which is less traveled, the occlusion-driven dentistry road. So we would have heard many people, many of our fraternity friends who didn't understand our path. For occlusion, 1-year course, it's a boring topic. There have been many speculations, but we all stuck to it and made this journey so wonderful. And I really thank our mentors for guiding us in this road which is less traveled with so much of motivation and inspiration. And actually, thank you, Anandraj sir, for being here. I've heard about Vishnu Dental College first when our mentors were conducting the course. So I used to think, who is that brainchild behind to teach his staff the occlusion so that it goes to all the students? And I've also heard many compliments from other mentors too, that regarding the sterilization protocol followed in your college, the line mentioned by that person was, I was floored the way the sterilization is maintained in their college. So might be one day I'm lucky to come to that college and see how it is. Thank you, sir, for being here. So this case today, I call it the story of missing 17. He is my pedo patient's father. His wife trusts me more, not the patient. So in 2022, when my occlusion eyes were blind, not opened, he came to me. And his complaint was pain in relation to 17. On clinical examination, all that I could see was just food impaction. But the intensity of pain which he came, he was so depressed, and but I could see wear facets in his upper and lower anteriors. So in that time, my knowledge was he has a parafunctional habit. So I told him, might be, it can be a pain related to your parafunctional habit. That was all I could say. And all I could suggest him was a soft splint in 2022. But he strongly believed that the pain is relation to the 17. So he went to some other clinic. He got the RCT done. He's coming back to me in 2023. You can see RCT done in 17 and lower also. All are zirconia crowns given by some other dentist. But his pain is still there, even after a year. And this time he said, the other clinic has not done the RCT well. That's why his pain is not subsiding. Even now, by 2023, I had registered our course. So I had some minimum basics. So I thought of giving him a deprogrammer. I told him, at least take this small clip which you can wear and see if your pain is reducing. Then you can understand what I'm speaking. But he was not in that mindset. He still believed that the pain was relation into that tooth. And he asked me to extract that tooth. I told him, even if I extract it, your pain is not going to subside. Again, no, he feels that I'm his child's dentist, a pediatric dentist, so I'm not capable of handling adults. So again, he went, and after 1 year, again coming back to me, he got the 17 extracted from somewhere else. Now his pain has shifted to the other side also, right side also, and he's having 2 more RCTs and 2 more crowns. This time, the decision was taken by the wife. She said, you better get it done, what she's telling. Because he's taking daily a Brufen, daily an analgesic, due to which he developed gastritis and gastroesophageal reflux, and he's having all these cervical erosions also. And the wife has to constantly hear, the pain at the home. So this time the decision was taken by the wife. So we start 2024, it was immediately after my second hands-on. I was full bang on to start the case. So on comprehensive examination, the main findings were TMJ, he had deviation and pain was more on the right side, but left side also he had. And almost all his muscles were tender. But the temporalis on both sides had high intensity of pain. But that has a problem. This DASA, I feel that cone triggers that temporalis. So it took some time for him to get adapted to the DASA also. And the dental findings we can see in the intraoral pics. This is how his anteriors were, and all with attritions and cervical erosions and bony exostosis. And you can see the tori mandibularis and the crown in 2-7 failing with metal exposures. So with our occlusion eyes, what are all the red flags we saw? It is the pathologic group function on both right and left side, on functional side, and non-functional interference due to the zirconia bridge in his 4th quadrant. Okay? So you can see the red marks till the posteriors. So we gave him a DASA, and during this lateral movements, the cone was going and getting locked on the left side, so we had to give a longer platform of the overlay. So the face bow record, CR bite, articulation, and you can see the first point contact was matching both intraorally and in the articulator. Actually, I took 2 CR bites because I was very apprehensive whether I'm right, and it was coming correct. So this is the basic equilibration chart and the treatment planning. So after working on the articulator, the idea I got was I can go with composite restorations in upper and lower anteriors. I didn't change the zirconia bridge. Actually, he was leaving to New Zealand in another 2 weeks. And I didn't know what the crown structure is inside. I didn't want to remove the zirconia bridge and traumatize the patient more. So I changed the 2.5 and 2.7 crown alone for proper contacts, and equilibration was on 8 natural teeth and also on the old zirconia bridge. That was the basic treatment plan. So this is the workout. You can see in that the lower, that zirconia bridge part, almost that buccal overjet was too much. It was as if it's a crossbite. So I had to reduce more of the buccal part of that zirconia crown. And equilibration in mouth. So I can't leave him a single day without a deprogrammer. So in between of transition to permanent, every time I can't keep fabricating a DASA. So in between, this picture is not clear. The same equilibration plate, I added a thickness and gave a clasp until he gets his permanent restorations. So this is the post-op pics. We can see it better in the, and you can see that both the pathological group function is transformed to canine guided. And the non-functional interference to the zirconia bridge is also relieved. Protrusive, actually pre-op in comparison you can see that it was more of a unilateral, but post-op we saw to that both 3.1 and 4.1 take up the guidance. This is how the beautiful dots and lines I got. You won't believe all the post-op pics I have taken only after 10 months. Immediately after completing the case, I saw the dots and lines and I sent the patient and he flew off to New Zealand. When he came back after 10 months, when I saw this contacts, the bliss I had cannot be explained. So this is the pre-op and post-op. So only with this case, I had not gone to a proper composite course. Only after completing his case, I went to the composite course also. How my composites could stay in a parafunctional habit person in the anteriors, in the incisal edges. So the belief I had in CR became very stronger with this case actually. So this is again the comparison, right side functional, non-functional, pre-op and post-op. Left side, protrusion, can you see it's more of a unilateral guidance which we changed it to bilateral one. And that 3.1 and 4.1 had a very inclined, sir used to say, no, that labio-incisal, I had to give it like that, otherwise it was interfering, and that is the thing. So what are my achievements in this? Patient stopped taking analgesics. So we made his day-to-day life easier. And no new signs of occlusal disease after 10 months. So no more new crowns and no more new RCTs. So patient accepted finally. But the challenges was, I told you, with the temporalis, it took so much time for him to get adapted to the DASA. I can't leave him with just the upper overlay because lower I had given him composites. So with the overlay, I didn't want that composite to get damaged. So somehow with a very blunt cone, pacing it more lingually, finally I achieved at a point where I could give him a DASA. And the lower old FPD was not changed. We got satisfactory contacts on that and patient symptoms were relieved. So what is the moral of this story? Anybody? In a humorous note. Yes. Listen to your wives.
For global peace it is necessary.
Huh?
For global peace it is necessary.
Not for global peace. You will not lose many things. Yeah. So jokes apart, we have made this patient's life so easier, so comfortable. So we are not just shifting the cusp tips and inclines. We are transforming lives for better. So be a proud stomatognathic specialist, and I am one. Thank you.
Wonderful, wonderful, Divya. That labio-incisal, I have to think whether it is a compliment or pulling my leg. Anyway, thank you, thank you. It was a wonderful presentation. Okay, great. We'll go to the next great man. Come on, Ronak, please.
Hello, good morning all. Myself, Dr.Ronak Shah. I am a general practitioner practicing dentistry, only dentistry, not occlusion-driven dentistry, since last 15 years. So there is one day, I met Dr. Ramesh in Hyderabad. At that time, he was not the mentor of Dr. VASANTH Dental Academy. So I told him, when you meet me, something new is going to happen. So it happened like that. He became mentor of Dr. VASANTH Dental Academy. And since I was about to register for the first batch, but somehow could not register. So second time I got a chance, and I was part of Dr. VASANTH Dental Academy. As a proud student, I am standing here. Before starting my presentation, this is my failure case I am showing because as I told to sir, I have lost all my data somehow. So whatever I am having right now, I am presenting it. This patient I have done around 5-7 years back with a confirmatory approach, right? So that is my heading, that I started with a confirmatory approach with not keeping occlusion in mind, right? But now I have tried to do in a reorganized way, the best way I can. So this is my patient case details. Patient is an office worker. So as in Gujarat, patient doesn't have time for doing anything in dentistry, right? Because he comes after 9 o'clock in the evening. So either we have to stay or we can walk. It's like that. So the chief complaints were like chipping of veneer in tooth 1-1. Pain was in upper left and lower left back teeth regions. Multiple root canal treatments in back teeth. Chipping of crowns in the back teeth. Occasional headaches. Difficulty in chewing. So on examination, I found out that patient was having a chipped crown and veneer crown preparation in tooth 1-1 was already there. Severe crowding in the lower anterior teeth. Chipped posterior crowns. Pain on percussion, tooth 2-7 and 3-7. So the dental history was like that. Previous endodontic treatment in tooth 4-5 and 4-6. Onlay crowns on teeth 3-6 and 4-6. Veneer on tooth 1-1 was there previously, but it is just chipped off. Medical history, no significant one was there in patient. So what I decided was that root canal treatment for teeth 2-7 and 3-7 as patient was having pain. Retreatment was done for tooth 3-6 as patient did not want to go for any extractions. Emax crowns for teeth 1-1, 2-7, 3-7, 4-5 and 4-7. Composite restorations for teeth 3-3 to 4-3 and occlusal equilibration. No, the patient formally declined the orthodontic treatment, right? And patient does not want removal of any tooth. These are the basic criteria that was deciding my treatment plan. So I was not happy with this too because patient is a clear-cut orthodontic one. This is my pre-operative photographs, intraoral ones, the chipping of veneer in 1-1 and the lower teeth are like this. So the ortho was the conventional one that I should be going, but patient formally declined that I don't want to go for any ortho. So this is the condition. So now I can see why veneer was not staying, right? It's not going to stay. And tooth 4-6 was fractured almost. Half of the crown was not there, so we have to do crown lengthening, as patient did not want to go for any extractions. Simple. This is on the left side. This is the condition of crown 4-6 at that time. It's fractured. We tried to say we did a crown lengthening and everything. I'm switching the extraoral photographs. So this is the ODBA records we took. And here we did diping preparation in the lower model, not the upper one. This is CR bite of the patient. This is the equilibration chart sheet. So we try to do equilibration in most of the teeth, except the prosthetic ones. This is the deprogrammer. Basically, in page on the articulator, we have given cois type. So this was the wax up done in the lower anteriors. As we have taken the CR bite, we thought that we need to build up the lower anteriors. We have done a PMMA temporary in upper, I think 1-1. Emax crowns were there in the posteriors. So we tried to achieve most of the occlusal contacts in the prosthesis. On the articulator first, we did cementation of the back teeth, basically on the posterior ones first of all without touching the anteriors. And this was the composite build-up. We did it with the index, obviously, but it was very difficult one for me. So just to get the acceptable context, this was the context what I am getting. So we got a decent post-operative intraoral and intraoral photographs with acceptable static and dynamic context. I am waiting for this patient for follow-up. He took an appointment on last Saturday, but he could not turn up. So I'm waiting for this, and I'm trying to get the patient convinced for ortho, so I can do better stuff with this. And patient is willing for ortho once I'm capable enough to do the ortho. He's fine with ortho doing with me, not with anyone else. Because he has been a dental patient since he was 7 years old. So he's like fed up of dentistry right now. So I'm waiting for the follow-up of this patient. Let's see. This is my presentation right now. I would like to thank Dr. Vasanth, Dr. Ramesh, Dr. Mala ma'am, Vijay ma'am, for making us capable enough to stand on this podium, first of all, and talk something about occlusion. Talk something about occlusion, not everything about occlusion, but talk something about occlusion. And apart from white and pink, now we can see red and blue as well in the teeth. Right, sir? Thank you so much for that. And you made us believe that whatever we are doing, we must know. Why we must know? Because as the saying goes, the things we don't know generally don't exist for us. Am I right? Generally don't exist for us. So thank you so much for allowing us, letting us know that you should know or you must know whatever you are doing in patient mouth, right? And ethics, you need to follow the ethics. I always follow a VDOM rule. That is, would I do it on me? Now I can say, if I can do it on me, then I can do it on the patient. Right? Thank you so much, sir, for allowing us. Thank you so much.
Thank you, Ronak, for the wonderful presentation. And thank you for finishing 3 minutes earlier. That's another good news for me. Thanking God for, so that you lost your, all your... I know how many slides you would have put if that hard disk was there with you. Just kidding, right? Okay, good. So we'll go to the next presentation. He is an amazing mentee. He is phenomenal, and he is the reason the entire Gujarat is here in all the batches. So he is like no words. Yes. So the moment I put the exercises, sir always says, they have enough in life, Ramesh. We are giving too much. Every time he says, every time he tells, that's reality. Even I know that. But every time this is the person you should scold. Because within 2 days, he'll finish everything. Third day, he'll put in the WhatsApp. Everybody will enter into a panic mode.
I finished my presentation before time.
I'll send him a book. Any book if I send, sir, finish, sir, next what? Every time next what? That is what motivated us to change the exercise from 150 to 165. He is the reason. Okay. So.
Sir, please don't start a timer.
Yes.
Yeah, before I begin,
Yes,
I would
yes.
like to apologize for my photography.
You don't have to.
I'm just a beginner in photography. So you can start the timer.
Yeah, wait. Wait one. Just wait, yaar. Allow me to speak. See, it's like that. Before we think about a question, she'll ask. She'll ask everything before. Before even Vasanth sir or me thinking about that to answer, she'll raise with another question. Yesterday, for the past 2 days, we had this experience. Okay, by the time I would have asked sir or technician there, she will start the same question. So Sabiha is a very, very special, I call her a kid in this ODD. Her journey is amazing journey. With 2 children, with all the struggles, being here. I know from where she started. That's a very, very proud moment for us. Thank you, Sabiha, for being here. With a lot of problems, she is here. With the kids are not well. It's not easy. It's not
sir.
easy.
Thank you,
And I need to thank your husband more than you.
Definitely,
Because
sir.
he is the
I
man.
would not have been able to complete the ODD without his support.
Now timer starts, dear. Thank you. Start.
So,
Start.
good morning. Hello, I'm Dr. Sabiha from Mumbai. And I'm here to talk about an integral part of ODD, and that is a roller coaster. Yes, my dear friends, neither am I joking, and nor am I out of my mind. And if you still don't believe me, then allow me to take you back in time to 13th November 2024, where we had a 37-year-old lady enter our practice, escorted by her husband, complaining of pain in an RC-treated lower molar tooth. On examination, the tooth was tender on percussion and it had a chronic abscess in relation to buccal gingiva. And by this time, she had already been to 3 to 4 dental clinics, and all the dentists had advised her an extraction, which she did not want to do. Also, the previous dentist had removed her crowns in the lower arch. This is how she had presented to us. And the dentist was about to do the same for the upper arch also, and that's when she considered visiting our practice. We took up the case for an endo retreatment after explaining the prognosis, and over a period of 3 to 4 appointments, the patient felt immense relief in her symptoms, and that really helped as a much needed trust builder in this case, and that also seemed as the right time to educate the patient for an ODBA test. And utilizing the aids of a presentation, kinesthetics, articulator, and models, I educated the patient with full confidence. And she did not take long to accept for an ODBA test. And by this time, I was extremely happy, enthusiastic, because I could see my first ODD FMR case in her. Over the next few days, I took the necessary records. Comprehensive examination was done for the ODBA test. I took the intraoral photographs, followed by impression, Facebook record, CR record, diagnostic mounting, planning the case, and sending it for a lab wax-up. By this time, I also had prepared a basic treatment, tentative treatment sequence of her case, along with a basic budget, as well as the time required for her case. And the next appointment of case presentation went smoothly, and the patient accepted the entire plan without any objections. And I was over the moon and super duper excited, super duper happy to execute the plan. But little did I know that my excitement and enthusiasm is short-lived, because the patient lost all communication and literally she disappeared. She was out of contact, and 2.5 months had gone by this time. And then suddenly one fine day, the patient casually just walks into the practice just to inform that now she wants to get her crowns done. But she gave a very little deadline, just 3 to 4 weeks she had in her hand. So already I was nervous because of this being my first case, and the time factor added to my anxiety. I proceeded with the provisionals. Unfortunately, my provisional set 1 turned out to be slightly higher, and because of that, I was not able to get occlusion despite equilibration. I lost a little confidence here. I was really doubting my CR record and my entire ODBA test and planning and everything. But still I proceeded with making the second set of temporaries, and I faced the same issue. What I missed to do previously was to do a gross trimming of the temporaries, followed by a finer reduction needed for equilibration. I did it this time, and I got reasonable context on my temporaries, and that was so reassuring for me. And I felt very much relieved by this. I forgot to tell one important thing, is that the patient was very, very, very unpunctual. Always she used to come late by 1 to 1.5 hours. So this not only took a toll on me and affected our practice, but even the patient, the number of appointments required to reach this far had increased. So this made her even more impatient, and she started losing trust on us now. And she gave a final deadline of just 10 days to complete her final restorative work. Now I could really feel a lot of pressure because of this, and hence because of shortage of time, I decided to do her case, the final restorations of left as well as the right side together, instead of doing it in phases, just to save time. So I started recording the master, I started taking the master records, and followed by the BIS trial. My challenges were not yet over, friends. I had to do the BIS trial 3 times because of lab errors. In the BIS trial 1, the posteriors were little bit out of occlusion, especially on the right side, and the anteriors were completely out of occlusion. I could just check the marginal fit in these, and I thought that probably the lab has done an error in mounting the lower model. I remounted the model myself, and I sent it back to the lab for along with the instructions. And to my utter dismay, what I receive as a second BIS trial is nothing but final glazed grounds. And look at the anteriors, they are still out of occlusion. The posteriors are still so high. And that was it. I just went through a very bad phase of breakdown at that time. And I was really not understanding where exactly is the problem with the lab. And my situation was similar to a beetle nut between a nutcracker, with the lab on one hand claiming that they had followed all the instructions and it is perfect on their articulator, and the patient on the other hand insisting and asking me how many more times will I have to come. I could not think exactly what to do, how to do. But then I proceeded with repeating all the master records. I mounted the models myself and I sent my articulator to the lab with a special instruction that please do not touch the incisal pin and the incisal table. And finally, here comes the final BIS trial. They had to do a little bit trimming of the tooth 3, 4, which clinically I had to do the equilibration on that tooth too. And finally, this was such a huge sigh of relief after so many challenges. And by this time, I was totally drained, not only physically, emotionally, and mentally also. These are the final photographs. But the final words of appreciation really touched my heart. When I asked the patient, how do you feel? She revealed to me that she's been a dental patient for the past 2 decades with so many crowns she's got done. And every time a crown was placed in her mouth, she used to feel an indescribable discomfort. And despite numerous adjustments, she never felt comfortable. And she told me that I was so scared when you were luting 12 crowns together that how will I feel after going back home? How will I be able to sleep? But she told me that I was amazed. I felt such a unique comfort with so many crowns together. And that was the first time in my life I slept peacefully at night. So I was finding it hard in that moment to stop my tears of joy. And that was my hard work paid off moment. And it was no less than a victory for me that time. So now friends, tell me, is it not less than a roller coaster? Yes, it is, but an emotional roller coaster because I've experienced each and every emotion depicted on this graph while doing this case. So I would like to conclude by saying that you will definitely face challenges in this beautiful journey of ODD, and yet it will never fail to fascinate us because of the fact that problem solving is the core of ODD. And to navigate ourselves out of these difficult situations in order to reach the ultimate goal of an ideal occlusion is the real essence of occlusion-driven dentistry. Thank you.
Thank you, Sabiha. A lot of, yes. We can know your struggles. Personally, I know her. The entire journey is not so easy for her. But the best part about her is morning she'll message me this, by night she'll be in a different mood. Okay, the entire third group is run by Sabiha, not by me or sir. The entire third group, WhatsApp group, by the time we see the doubt, by the time we think about answering, she'll come up with a lot of answers. All the doubts are answered. No, they answer themselves. They put their own question, they struggle, they fight among themselves, and they'll find a solution. That's the beauty. Thank you, Sabiha, for coming here, because I know how critical it was. Thank you once again. Thanking God for you. Okay, so now comes the next person. Yeah, come on. Blessin. I'll always call Blessin. My wife always calls Blessin. Correct? Blessin is right? Come. He's a phenomenal clinician. I know his handwork, I know his composite work, I know his Veni work. The problem is he'll get the maximum mood to work just 2 weeks before hands-on, 1 week before presentation, 2 days before presentation. He was the last one to go out of the hall yesterday. Okay, he was there correcting everything, finishing everything. He'll become phenomenally too good, but just before the exam. That's all. I know how you would have done you would have done the same thing in the college. Okay. Yeah, start.
A warm good morning to all of you. As I said, I was always a backbencher and I love to be there for the entire life because 2 things happen. Now, you see always people in front of you, so you can follow well and you can take whom to follow and whom not to follow. And when you look back, you are not followed by anyone. And this is a dream, and this stage is a dream for every ODD dentist I know. And I thank Almighty that I reached here, and I could get good mentors, good co-mentees, family. Everything was all set for this course and for my life. And for the case presentation, this is a 56-year-old female patient, and the patient was referred by her dentist doctor to my clinic. And no, normally when we start a course or something, we used to post in different groups or in status. And by seeing the status, the dentist referred this patient to me, her mother, and she used to travel 50 kilometers one way to my clinic to get her treatment done. The chief complaint was there was pain on her upper and lower right back teeth, and there was some difficulty she felt while chewing the food. And on examination, I felt that there was pain on percussion with respect to 1/6, and there was signs of occlusal disease. So I referred her and advised her for an OPG. And this is the OPG. You could clearly see that 1/6, there was a percussion involvement, there was a fracture, and I could not save that teeth, and I was forced to extract, and the pain was gone. But I asked her to take up the ODB test because there was so much of occlusal disease signs in her mouth, and she gave consent for that. And this is the intraoral photos just after the extraction. I think it's 2 weeks post the extraction. This is the upper, and this is the lower, and this is the maximum intercuspation. And when I evaluate the dynamic movements, there was so much interferences in the protrusive and latrusive movements. This is the groove function. Even though the premolar has left, the molar is in contact when you move to the left side, left latrusive movements. And my occlusion eyes was open by that time, and I could see the fractions all around the lower, especially the lower teeth, especially the posteriors. And this is a 4/7. There was ceramic chip up due to the protrusive interferences. But before the, normally the challenges happens during the ODD phase, but I got the challenge before that when I removed the crowns, and this was the situations. And she insisted that she doesn't want implants and she doesn't want a removable process. So my motive was to reconstruct everything, the post-endo, do re-RCTs for so much. And I think it took almost 2 months to complete this foundation. Then I moved on to the ODBA test. So impression was taken. As usually the protocols was followed, and course deprogrammer was given, and dose by manipulation was done, and the lot test was negative. This gave a green signal for me to go ahead with the FMR, as I got a stable TMJ. And this is the orientation jaw relations. Face bar transfer was done, and vertical jaw relations was done. Centric bite was taken, and the first point of contact was checked in the upper and lower jaws. And what matters is accuracy in every steps. So mounting of the semi-adjustable articulator was done, and the first point was correlated. And this is the first happiest moment in my life after I entered into this ODD journey. Now I am happy that I can move forward. And this is the equilibration chart, and it was a combination cases, restorations in the anteriors, and some crowns I had to replace in the posteriors, and as well as equilibration in some of the posteriors. And this is the detailed lab instructions. The first time I've heard of such a thing. Normally I will say do wax up, send to the lab, and they does the wax up. And after reaching the course, I decided to do this detail, and actually they were surprised. They started calling for this wax up. I got almost 10-12 calls. So what is this, what is this? Otherwise they will just wax up and send it. And thank you for that. Now the lab is very afraid of me. That's what I would say. And I got because they will see every detail in my lab instructions form and on my case. That's the blessing I got with this course. And this is the equilibration in model I have done. For the anteriors, I got the anterior coupling, and some of the posteriors, except for the crowns, I did the equilibration. And then the lower, for the anterior coupling, I did the composite on the mock-up. Then it was sent to the lab, and the functional part was, the functional wax-up came. I think it took them 2 weeks to send it back to me. And the goals of ODD is, as you all know, dots at the back and lines in the front. With that aim, I just started my intraoral adjustments with equilibration plates. And this is what I got. After equilibration of the posteriors, I set the anteriors because I got the left side canine in occlusion, and all other anteriors I have to build up with wax composites. And I have done this case till this phase only. Then after next week, I will be doing replacing the temporaries and looting the all other works. And this is the thing I got, and the dot of happiness I've got after seeing this. Now I think I took almost 30 pictures, and I felt happy that I could get at least this dot. It may not be a good one as Sir has told, but I hope that I reach somewhere. And next treatment plan, following the PAP rule, I'll be replacing the first I have to set the anteriors, that's the crown and the anterior. Then again CR registration, then replacing the posteriors, big trials and occlusal adjustment, crown cutting, and again equilibrating. To protect the stomatognathia system, I'm planning to give an long-term overlay deprogram as night guard and follow up every 4 months to check the occlusal status and equilibrate. And this is what is my motive in my life. It's not who you are that defines you, it is what you do. It is what that defines you. Because if you are a good ethical dentist, it is what you do that defines you. And that is what Dr.Blessin George, stomatognathik specialist. Thank you.
Thank you, Blessin. So happy. So you just like I can see your dedication yesterday. Next comes a wonderful presentation. He has the next plan also to do the case, and we have one of the biggest star. I don't know what he's going to do. I'm afraid the stage has to hold him because he may start dancing after presentation. Yesterday he was dancing with the certificate. By this time everybody knows who he is, right?
Good morning, everyone. After completing 1.5 day idea workshop in Bharuch, I think now I am occlusion specialist. In
the first hands-on he was saying, "Sir, what are you teaching?" I thought I learned everything that 1.5 days. First hands-on, first day, he was like, "What are you teaching?" There is so much into this field. I am really stunned. That's the way it is. He is a very, I always name this as like very reliable batch. The first batch is a pioneer batch, and this is a very reliable batch. The moment Ronak posts something, Radheshyam has to reply with a WhatsApp exercise. That's a rule. It's a rule of the day.
That exercise, remember, you are supposed to finish before 30th of June.
Yes.
2024 or 25?
Whenever I post exercise, he is the first person. Is it 2024 or 2025, sir? I posted for 2025 to for finish. Okay, he'll bombard, and he is the one person whom we decided later, after posting so many exercises, we decided let's stop posting in WhatsApp. You think about the amount of bombardment you would have done. Completed, sir. That gives me kick, sir. Please don't stop that. Okay, so I welcome you, sir. Great to have you here.
Thank you, sir. First of all, thanks to Almighty God and my mentors, Vasanth sir, Ramesh sir, and especially Ronak sir, who give me opportunity to like say something at least here. So please forgive me. And okay, so this is patient Suresh Bhai, and he came for especially the correction of his smile correction. And after comprehensive examination of stomatognathik system, radiological examinations, these are the intraoral photographs, impression taken, and then anterior deprogrammer was given for 15 days to settle his TMJ. And after 15 to 20 days, I take this CR bite. Face bow record was done, and upper model was done with face bow, and lower model was done with CR bite. Treatment planning was done, and wax up was done, and these are the temporaries was given with Protem. After 15-20 days, with the help of PAP rule, we completed his final restorations. Okay, these are the dots in posterior and like lines in anterior. Sorry, I am not good in permanent. No, sir. These are not permanent markers at all. So nice canine guided occlusion was given on both sides, and a very happy patient. And in follow-up, again anterior deprogrammer was given, and these are the follow-ups. Model was taking, and this is my journey. Yeah. And especially this is like 6-month follow-up. So I'm very happy with this soft tissue as well as hard tissue. Protrusive guidance is maintained. These lines, dots everywhere, and thank you.
Oh, fastest FMR done in the history of ODD. Thank you, thank you, thank you, thank you. He has delivered more than 150 deprogrammers in this journey. That's a huge achievement, and he is like an amazing clinician. He doubts everything, and he finds his own answers, and he takes it everything very, very easy. That's the part. Some people are getting tense. No, what to do? He never cares about the mentors or the subject or anything. He knows what he can do, and he is best at what he does. Okay?
15 minutes session every day. 15 minutes
Every day, a life of Ronak, he has to spend half an hour to 15 minutes of his life, not even to his wife Pooja, but to Radheshyam sir. It is a golden rule written. Whenever the phone is busy, no, we should understand these two people are talking. Pooja and Ronak will not speak. That is how, thank you Ronak for pulling him there. I have to definitely thank you. Many people will always ask doubts with Ronak. Okay, so now comes the next person. Yeah. Monica. You can go. They should know whom I am talking about, right? Yeah. She is like, she was in one of the IDA. She came to me here. Sir, I want to join. Who are you first? Okay, what do you want to join? So that's how she was very adamant. I said, wait, let's see. Because whoever inquires, it's not like everybody who inquires, we just give a seat. Frankly speaking, we just analyze. That's why we have a special one-to-one session where sir, me, and we sit together as a team and talk to the participants. End of the day, I see people, 60, 80, 70 people sitting in a big course, getting the photo, putting in the Facebook. It always hurts. Okay, Facebook. Instagram. I never get this word, Facebook. It always goes to Facebook. What to do? Okay, that is how she entered. She bought Corident, and she lost hope. Then she bought Artex. I don't know what curse she has on articulator. Somebody broke the simple part of articulator. She lost another 30,000. But still, among all these struggles, I know her family, I know her situation. With this, she wanted to really upgrade. But she wanted to do too many things in life. She is already in POS. She was already, 2 days before she was in CPD. I don't know where she will run or how much she want to learn. Welcome, Monica, for ODD Symposium. You can start.
She's the only one who has taken retake as well in our batch, sir.
Retake also she was there.
Very good morning to one and all present here. I am Dr. Monica. I am presenting a case involving equilibration with composites. A female patient aged 52 years reported my clinic with the chief complaint of having a sensitivity for the past 5 years, having no relevant medical history and dental history. Extractions done in 4/7 few years back. An intraoral examination, 182838 and 4/7 were missing. And a mild attrition with dentin exposure is seen in 4/6 and 3/6 and some disease. An extraoral examination, muscles, no symptoms but signs of occlusive disease were present. In TMJ, no symptoms but signs of occlusive disease were present. This is intraoral photos. And in dynamic movements, all the interference seen in the protrusion, in right laterution, both function and non-function interference is seen. In the left laterution also, both function and non-function interference is seen. The patient is made aware of the damage developing in the stomatognathik system, so advised for the comprehensive examination, and patient accepted the ODBA test, and ODBA test is performed, the upper face bow record, and the lower CR bite is taken with the palatal type cois deprogrammer, and upper model articulation is done with the face bow record, and lower with the CR bite, and first spine contacts were matching in the both in the intraorally and the model. Mind mapping is done. With the CR at vertical 3 mm and at MIP it was 1 mm. So with the posterior segments removed, the contacts were seen in the 1-3 and 4-3. So plan to retain that contact, and equilibration started with the posteriors and achieved all the static contacts in the teeth to be equilibrated. Finally, the vertical arrived at 1 mm. The anterior contact is seen in 1-3 and 4-3. Plan to retain this contact and to build the others with composites. And composite build-up is done in the model by me. And the occlusal scheme planned is right side canine, left side canine, the protrusion with the central incisors. After composite build-up, all the static and dynamic contacts are achieved with no interference. So in my follow-up steps, I have to achieve the same and to execute the plan in the mouth. For that, I need an equilibration plate. I will fabricate the equilibration plate and equilibrate in the mouth. After achieving the static contacts, I will add the anterior addition with the temporary using index. Once I achieve the static and dynamic contacts, I will do the permanent restoration in the anterior with composites and the proper rubber dam isolation. And DASA will be given as a night guard to protect the stomatognathic system. And follow-up will be done once in every 4 months. Thank you.
Great, thank you. Thank you, Monica. So when they came forward to present, I was happy. So we wanted to accommodate everyone. End of the day, we cut short all our presentations. We want you people to present, okay? So thank you, Monica, for that, okay? Then I call my dear friend, and we have been together in courses, learning together, traveling together, and a lot of courses we have done together. End of the day, when she asked, she wanted to join, I just asked her, why are you joining here? Already we have done together. We studied together. What is the point in joining here? Why do you want to? No, Ramesh, I want to come. I want to learn from sir and you. So I couldn't say no. That's how she joined. So welcome, Dr. Jyoti. Give a good round of applause. So after this, we'll have a coffee break. Okay? Yes.
Hi, good morning. I'm Dr. Jyoti. And like Ramesh said, we've had this journey together. I've been to Dr. Vasanth's clinic earlier, did a program with him. And just after that, Ramesh announced ODD and I said, yes, I want to join. So he said, sure, you want to do the first batch? I said, yes. So I've been at this since I started practice in 2001. Occlusion seemed to fascinate me a lot. My first articulator was bought in 2002 when people didn't know articulators in Delhi. Nobody wanted to give me one. And my lab technician said, if you have one, I can probably try and work on it. And so it was a bioart, sir. I bought it from IDS, and my lab technician was from KGMC. So he said, you bring it over and we'll work. Finally, it was sitting in his lab and it got fungus, so I had to throw it away. Okay. So that's me. I was always wanting to study. And my husband told me way back when we got married that so long as you don't ask me to study, you go ahead and do whatever you want. So I went ahead and did my postgrad at NYU in endodontics, my second love. Then I did implants because I thought, if I can't save, then I have to replace. So that was me. Then occlusion was then a worry, now a worry, because that's what was most important. So first, I want to thank God for getting me through till here. Next is to all my teachers, to sir, because he's changed so much in the smallest of things that I see today. So I have to thank you, sir. Ma'am, for getting us through this with all the love and affection. Ramesh, my best friend, on all these things. I will get one fine day a message, you're presenting, that's it. Malar, she's the backbone. You can always ask her, turn around, and she'll be right there. Yes. I'll fail in my duty if I said I'm here because of my parents. My father's no more, but my mom is a driving force. She calls me religiously. She called me twice yesterday to wish me all the best of luck, and today morning as well. My husband, my kids who've lived with me with doing dentistry 24/7. My doctors who work with me and find me very difficult, my assistants who are working on my presentations and my photographs. So there's so many people to thank because this is not a one person's job. I can't be here without all of them getting me here. So I have to thank and mention all of them. Yes, and my lab technician, Hemal. I know a lot of you are unhappy with him, but he's one guy who, if you talk to him, he understands, or maybe because I have a one-to-one with him, he's been very helpful. This case was a case of no preps. I haven't touched a tooth because it was a very big challenge to touch this case. This girl is a young 23-year-old. She came with acute sensitivity and she had had multiple consultations. She's an assistant to an orthopedician. And he first off told her that she needs facial correction surgery. Without that, she cannot live. An orthopedician, not an orthodontist. People advised her orthodontics. And by the time she had come to me, she had had about 15 consultations and no treatment done. She had very severe sensitivity. She could not have even normal food because she was very uncomfortable. So when we looked at her, it was Engel's class 3. Her lower jaw was forward. She said she's had this since birth. So her mother also has small teeth. She also has very small teeth. We did the OPG. And I sent the OPG out with my diagnosis to all my OMR friends, and they said, wow, bang on, ma'am, you've got a case of amelogenesis imperfecta. How are you planning to treat this? And that's what Shanmugh Priya was asking me, why you didn't give her any other format of restoration. We do that discussion over the course of time. We did TMJ exam, no problem. We did muscles, we knew she had discomfort. We looked at her teeth. We were very close to exposure. I didn't want to do a root canal because I thought if I'm going to do additive work, I don't need to be there. So I didn't do anything. Everything else looked normal. In her medical history, we only had a vitamin D3 issue. Nothing else was reported. No caries, all gums looking fine. So there we were. We were ready to start. We gave her a lower deprogrammer. She didn't want to wear one. I had to really convince her to start wearing one. She started wearing one, her sensitivity was gone. Then we did all her records, and here the most important thing to me was the minimally invasive. How was I going to treat her without having to touch her? Because I had no enamel to bond to it. I was only working with dentine, and I didn't want to cut, and she already had enough spaces. So, the limitations of this case were amelogenesis imperfecta. Patient didn't want too long a treatment because of her wedding, and she didn't want to spend any money. So then we did her comprehensive exam. We planned on a semi-adjustable. We did the wax up. We did documentation, and then we started with doing her final restoratives. That's her OPG. That's her clinical photograph. That's her right side, functional, non-functional, protrusive, left side. I had nothing to prepare. I couldn't. I had so little to work with. I didn't want to touch it. This 4-1 was very sensitive. We took her preoperative records. This were her photographs. That's her scans. That's what she finally wore for a few days before I took her records. First point of contact was on her laterals, and then shift the slide back 5 mm of slide. Same contact on the articulator. We decided we were not going to reduce anything. We only had to add. And then we went into a discussion in the lab as to what we're going to restore it with. So he had done previously 2 cases with amelogenesis imperfecta, and he had treated it primarily with PMMA. Reasons were basically, 1, we can't bond, we don't have enamel. 2, we didn't want to cut zirconia, we didn't know how much we were going to manage. Posteriorly, we had nothing. Incidentally, I didn't want to cut again. Whatever natural space was there was all we were using. So we planned the wax up. I had a red flag. I'm going to mention it a little later. That's how her wax up came back. We made her index. We made her temporaries outside. We did cross mounting for her temporaries as well. And that's her when we did her temporization. This is a day later we took her photographs. Right side, we managed to give canine guidance. Left side, we gave canine guidance, but she would break the left side. She'd bonded the entire segment on the upper left. So we went back, we re-restored her thrice. We kept this on for the next 6 weeks. That's her smile on her temporaries. Now she had become comfortable. So she kept telling me throughout, I want to take them out. And then we realized her vitamin D was bothering her. We gave her support. We started her on medication. She got better. Those are her scans from her temporaries. So when we took out her temporaries, we recorded all 9 bites. Ramesh presented this to us, and I had to clinically do it because we took out her upper temporaries, lower temporaries, kept the posterior stable, and we went ahead and did the interarch record. Then we went back, put those temporaries, and recorded upper and lower arch bite, so that the lab had a clear indication how they'll be able to restore her teeth. Despite the fact that he was wanting to do a digital prep, we told him he should go with what we're giving him. So they were patient enough to do it our way instead of doing it their way. Those are her final scans. So if you see there, there's space in her posteriors. The only space I made was for interdental space between her upper 6-7 on both the sides, right and left. So I took a torpedo red ring and just went through so that he had enough space for the material. That's the lab instruction. We were doing PMMA, so we told him, once you've printed them, we are printing them with the right side being canine guidance and the left side being canine and first premolar. That's the mounting, the anterior bite, and that's both sides posterior. We had to join these units. We couldn't give her singles. We were joining them for a little bit of strength and to be able to manage the space. So we had some space and we were blocking some. The problem we faced primarily is between her lower premolar and canine. We had a lot of space there. Those are her exocat plannings as they came from the lab. You'll see the units are joined. That's the remounted finals, PMMA, on her articulator. That was our bonding protocol. We did a split dam. We put her under Articane. Then we did Concepsus. We went ahead, air dried. We went ahead and did clear fill SC, prime, then bond, leave the bond for about a minute, and then we did heat cure composite, heat treated composites, flowable, bonded, and then we removed excess. So tack cure and then remove the excess. That's her final. Upper aesthetic, lower aesthetic. This rest. That's the occlusal. Yes. That's the right side functional. She's on canine guidance. And on the left side, she's wearing a dasa. That's her smile. That's her review. Thank you so much. It's been a pleasure. Thank you so much, sir.
Thank you, thank you. I didn't press that buzzer, yeah? Okay, great, great. It's a wonderful presentation. It's a life-changing moment for the patient. You can imagine, no, how that patient would have felt. That's the beauty. But believe me, without knowing occlusion, attempting something like this will be a nightmare. We don't know what we are doing. We don't know what we are going to achieve. Okay, so it was wonderful. And she took another 1.5 minutes extra, but that's okay. Because a lot of people, Radheshyam sir helped, Monica helped. It was with their help we are able to achieve this. We are able to allow this 1 or 2 minutes. Okay, it's a team effort. You have to think everyone here will finish fast. Of snacks for ODD journey. The best part is, suddenly I'll find out, no, they'll be eating something. When I go near, no, they'll give one piece to me, sir. So that I don't reveal that secret. They are so thorough, these people will not leave us till 10, 11, 12. I don't know what time it's going to get over. They have decided to bring the snacks. Last time she says, just 5 kgs this time, sir. 5 kgs. Huh? And let's keep it a secret. Okay, let's start the second session. From here on, no more coffee break, nothing. It will be non-stop. Our target is to finish by 1 and 1:30 will be the lunch. Okay, so stick to the time. I was very happy. The greatest presentation is 2.5 minutes. Yeah, if people like you are there, then people like us can survive in the podium. Okay, fine. So next we are going to have a presentation. You always see her at the back of the stage. But every presentation of mine or every work of whatever we do, you all know whom I'm talking about. Okay. So this is the first time in the ODD platform she is going to present something. It's not a big thing, but she is going to talk in this platform. So the real face behind me, behind all my presentations, behind all the hard work, and she is one woman which I love to have for 1,000 generations as my wife. Okay. So I welcome Dr. Malar. This is not a 10-minute slot, but try to finish as fast as possible. No, she always calls me, no?
So very good morning everyone present here, and I would like to congratulate all the mentees present here for your wonderful 1 year journey with us and for this grand finish of this wonderful day. Okay, with this note, I thank Almighty and start my presentation. This is Dr. Malarvizhi Ramesh from Dr. VASANTH Dental Academy. First in front of you all, like I would say like a dubbing artist coming in live to present and to be a face of, like to see as an presenter. Sir? Background mentor. Thank you, sir. Thank you so much. Okay, today's topic will be like my topic, that is the ortho. The art of embracing ODD in orthodontic practice. So why and when and how. So I just want to assure and reassure why orthodontics is important in your ODD journey and how you go about it and when all you need that ODD and ortho together. Okay, so you have to think your joint first before you think of your teeth. So that is the motto of our course, of course. So I just want to reassure and make sure that for each and every individual patient, you make sure that you embrace or at least give it a thought of why not this, okay? But it should be the first, okay? Okay, with that note, you should, and if you are brave enough to start, you will, and you have already done that, and congratulate all of you for that. So I personally thank my orthodontic and occlusion gurus here, none other than Dr. Vasanth sir first, because of the seed which he had given me. And I stand here with all the shoulders of giants, like as sir said. So he stood on Dawson and Stewart, so I am the topmost now. I'm standing on sirs and Kaushal sirs and my guru at home, of course, yes. So I nudge him, I torture him for all the doubts and knowledge more than you all, so that I get and learn more than from him. And Dr. Kaushal sir is also my orthodontic guru. I want to thank personally sir and Kaushal sir and Dr. Ramesh for all the knowledge I've gained from. Thank you so much. So the topic is why, how, when ODD in orthodontic practice. Without any delay. So why ODD in orthodontic practice? You know that, right? Why? Because mandible is the movable bone in the whole body and it has a location awareness with teeth. So it has the proprioception. So of the 25 to 30 microns, that's the crux of all the work we do. And so, any orthodontic movement on a tooth will have a direct impact on our stomatognathik system. So, we cannot think that this will not have an effect. So, what is the goal of ODD philosophy now? The TMJ has to be in stable position and the muscles has to be in harmony and all the teeth should have what? Static contacts on all the ideal or near ideal location and dynamic contacts should be as far as away from TMJ during the latrusion and protrusion with the planned dynamics, okay? So next, so what is the ideal non-invasive way to achieve this ODD philosophy? Is it the reductive reshaping, which is the equilibration, or is it the additive, which is the restoration? Of course, you all know the answer by now, which would be most suitable, the most non-invasive way, the very first R in the triple R. You all know, right? It is the repositioning through the orthodontic, which is the ideal way. I just want to reassure again and again so that you will be able to have that thought process first in your mind. So we come across so many different case scenarios in the anteriors. The most important part of the third leg of your tripod, that is the ortho. You all can recollect it, right? So you all know the scenarios. By now, you can just do the actions of 1, 2, and till 7, and how you are going to treat that with all your exercises submitted. So I'm just going to show some cases. So different case scenarios, you can now even start your mind, which is the case scenario here. What you're going to do with this? What is your first thought when you remove your posterior segments and you see the anteriors in your articulator, right? So what is the case scenario for this? Can you even imagine? Can you see where the lower anteriors are lying even in the MIP? I'm not talking about the CR even. So it has to go still more beyond. So what about this? So what is the best treatment option for all these situations? Without any doubt, with your closing your eyes, it is the magical orthodontics. So I'm proud to say that. So I have just briefed you about why. So when ODD in orthodontic practice, we have 3 categories for that. One, when the patients comes directly to you that they need some orthodontic correction. Okay, and number 2, they have undergone orthodontic treatment before, but they're not happy with the results. And number 3, as a part of an ODD treatment protocol, we treat the patients, we select the tool as orthodontics to treat the patient to achieve what we need in the ODD. So that can be for 2 categories, one patient with the stable joint and one with the unstable joint. We'll just brief out of what can be done. He's asking me to move aside. Okay, for first category of patients, orthodontic corrections, where they come only for the orthodontic corrections. So these are all the patients where they come for the alignment purpose, they come for the debite purpose, they come for aesthetic purpose, they come for functional purpose, they're not able to bite properly, they're not able to chew properly, their teeth are not in alignment. So these are all the cases where they come especially for the correction of their teeth as a part of only for the orthodontics. So the second category is the patient is undergone a treatment somewhere, they've come to us again because the treatment needs are not been met. So what you're going to do with them? Again, some additive or restorative, or again the ortho part. Just give it a thought, no? So she has undergone orthodontics 4 years back. These are all real patients of our clinics. So they've undergone orthodontics 4 years back, and still gap still remains the same. And this patient has got a relapse from her orthodontic treatment done in her childhood age. So she has come for that, and this patient, immediate relapse after the orthodontic treatment completed. So what is your thought process again? Category 3, the patients with stable joint, and we planned that after the planning in the articulator, we planned that patients needed the repositioning, that is orthodontic tool to be treated. So in that case, so we take the patient from here to the ortho part as a part of an FMR journey. So by now, I think you will be able to recollect and you will be able to assure me that every FMR case, every orthodontic case is every FMR will have this tool as the first part, okay? So third will be patients with unstable joint. They have come again for the treatment for the FMR, and you see that patient is not having a stable joint, but the patient needs the ortho part. But what you do what is something called as, of course, you take the MRI part, I'll give the treatment part later. This patient has come to us with the report, with the anterior dislocation of right articular disc in closed mouth position without recapture in the open mouth position with this something serious. So we treated this patient. One more, this is the intraoral pictures of the patient. One more patient, and she has got anterior disc displacement with reduction in left TMJ, normal right TMJ, and all other this is all normal, but the left TMJ has some problem. So these are all the categories of patients you see in your daily life. One with your category 1, 2, and 3, all the patients are coming for ortho, failed ortho, and as a part of an FMR, okay? So this is that patient. So ODD philosophy in orthodontics, again I'm reassuring, will always be the best treatment tool to achieve results in a non-invasive way. As you can see, remember every orthodontic case is a FMR case. So how do you go about it? I just want to brief the steps of all you have learned in this 1-year journey of how you go about do your orthodontics in your ODD, with your ODD philosophy, okay? So we know that there are two category of patients, one with stable joint and no muscle symptoms, and category 2 will be unstable TMJ with or without muscle symptoms. For category 2, the treatment will be, you have to extend your reprogrammers for a few more days or few more months, or again with a permissive occlusal stabilization sprints till the joint gets adapted or joint gets normal, and then you go about your category 1 steps as such, okay? I'll just brief what all you have to do in your this thing. Step 1 will be, you have to first come, you have to solve or manage a chief complaint, and step 2, all your ODBA test with your records and with all your exercises, whatever you completed in your ODD journey, make it a plan and present to the patient. So comprehensive consultation and the patient consult will be a third step, and the TMJ joint-based ortho diagnosis and final treatment plan. So one more added with your ODBA test. So it is a TMJ joint-based orthodontic diagnosis and final treatment plan. And you start your orthodontic FMR. So before that you do the equilibration in the model and equilibration in the mouth on the day of bonding. Okay? So before equilibration, before starting, you have to do the equilibration and start. And this is the start of orthodontic treatment. So during the every 2 months once, what sir says, so we do the major corrections of the interferences only in the static parts, in the posteriors, and then in between ortho, that is what I'm saying, and between ortho you do the equilibration. And before debonding, we can do the ODBA test, which is an optional thing we usually do in our clinic, but after debonding, we have to just complete the part of what happens, and then the treatment is completed either with the equilibration or restorative tool. Again, as a part of completion, we give the lower fixed lingual retainer and upper, it depends, what night guard or Essex or DASA, depending on the patient's condition. And every 4 months once, we follow up the patient, and if equilibration if needed, because the occlusion is dynamic. Okay, you just take the photos. I just rush through some the OTD protocol, the ortho done with the OTD protocol in our clinic. This is the patient which I showed you initially. So this is the pre-op and that is the post-op. And this what makes us happy, right? All the dots and the lines with our ODD done in all the ortho patients. Okay, this I just want to make sure that this is the significance. This is like wherever the patient, which category the patient comes, maybe like, okay, if it is coming from ortho or it is from failed ortho or a protocol of your ODD philosophy, but we have the right tool in our hand to finish it properly in the right occlusion of whatever the patient's teeth needs it. So that I want to just ensure and reassure. So this is the post-op. You can see the difference. And so you can see the changes also. With the ODD philosophy, with your joint going back to this stable, home, harmonious position, you can see all the changes in our extraorally too. I'll share some smile stories from our clinic. This patient is the first patient which I sent to sir for diagnosis, and I have treated this and completed this. Success of embracing ODD in orthodontic praxis, I just want to again show you all the dots and lines which makes us happy as ODD persons. Some more smile stories, pre-op and post-op. From case scenarios to case scenarios changing. Again, the success. So morning when Blessin and some of them said that when we see the dots and lines, we get that joy. That, he said like 30 photos, no? He'll be like taking some 300 photos, which I have to, again, so it happens. So we could realize, I mean, we could connect that joy which you are sharing too. So these are all the completion part. And just I want to complete it with one special sign. I showed you the part as anterior dislocation of right articular disc, and we treated her with the stabilization splint. And after exactly a year, she comes back with no significant demonstrable abnormalities noted in both temporomandibular joints for clinical correlation. So this what makes us happy, right? We have that magical tool to make that happen. Whatever the patient is relieved now. One more patient, it is like a coincidence, maybe we can say. The same day, a year back, and the same day, this 26 Feb 2021, this is 26 Feb 2022. She has got anterior disc displacement with reduction in left TMJ, and after a year of treatment, no significant abnormality is seen in both TMJs. So can I now call ortho as magic and ODD as magical part in that? Yes? Yes. Thank you. Orthodontic treatment, so done with respect to TMJ is a must. But as an ODD dentist, completing that case with dots at the back and lines in the front will give long-lasting, stable treatment results and the satisfaction to us as a person, human, and with all the ethics we follow, right? I would like to thank Almighty and my parents and especially my kids for all the support, for all the mentors here and mentees here. Yeah. True. And especially to Dr. Ramesh. Thank you so much.
Okay. Thank you for this presentation. She is almost convincing everybody for POS. Okay. Yeah, it's a big thing, yaar. It will be a big asset. If husband and wife are here, both of them are dentists, believe one person, make them learn ortho. It will make your life easy. Now you don't have an option. It's already, it's already done. Okay, at least find a good buddy who does that job, who respects your words. That's very, very important. Every time we start a case, the biggest problem is I'll give the case within 6 months. I'll ask, when will you complete? Because that patient would have asked me 10 times. Then I'm answerable, no. So one point of time I'll see, like, she'll say, if you give me 3 months, I'll change this case scenario. We talk like that. Case scenario 3 to 4, 4 to 3. We talk like that. No, so she gives a stubborn answer. So whenever we send a case for POS consultation, all these POS dentists behave only the same way. Why I'm saying this? If you show them 2 pictures and OPG, you send the records. They'll put it in the software. Then only they'll utter a word. I'll tell you, patient is waiting. Consultation has to be done. No, I need models. I need to study. Exactly how Vasant sir speaks, the exact tone she'll speak. Okay, the problem here is, I'm here to convince, educate and take them take the treatment, but I have to do all this job. And she's like a boss now. Okay, she enters like a super specialist inside, directly does what she wants, because equilibration in the model, mouth, everything complete. No, directly she puts the bracket. In between equilibration, she'll call this poor fellow, come, you do it. Okay, so the journey, what I'm trying to say here is, 40 patients per Sunday. Every Sunday we'll have 30 to 40 patients of orthodontic. I don't know what orthodontics we did. What my consultant did, I don't know. Do you understand what I'm trying to say? By the time they get ready. It was a very, very tough journey, believe me. Then I went into orthodontics. I studied for 1.5 years in an academy. I started practicing. Still, I'm not very, very happy. Because end of the day, they'll show a OPG. No, it will be so nice to see the parallel roots at the end of the treatment. That is something phenomenal which I have not seen in any system, which is so well thoroughly planned. 16, 17 documented pages they'll give before starting the treatment, how to start. That's something it floored. I blocked the seat for me. Then I decided it is too much for me to take up another big burden. Maybe Vasant sir can handle both, I can't handle. So I decided better give this to Malar. The best part is, when she started ortho, she hates ortho. Okay? She doesn't want to do anything in ortho because we didn't have the best of thing. Meenakshi is best in everything. For us, I don't know that particular department. We couldn't get anything. Sir can easily relate. By this time he knows who is it, right? So what I'm trying to say is, orthodontics is the main tool. Many people asked me. I told you before finishing ODD, don't jump into anything. But now you are free to jump into anything because you know occlusion. Go anywhere. Don't argue with anyone. Don't talk to anyone. Just sit and learn. Then you analyze. End of the day, you will realize this is the base of everything we do. Okay. Thank you, Malar, for this wonderful presentation. Thank you all. Sir, The great man. Thank you for coming. Your place, sir? Nagaland. Nagaland. He is coming from Nagaland. He's like, the best part is, he'll just observe in the hands-on. Okay? The amount of work he does, the cases he presents, it will be phenomenal. We think like whether he, many a times, sir, to be frank, I doubt whether you understood or not, or what reaction is giving. I'm not able to, generally I read faces. This is one face I cannot read. Okay, only thing is after seeing the work, I'll be able to read. So, happy to have you here. You can start your presentation, sir.
Thank you. Good morning, respected mentors, special guests, and my dear fellow colleagues. Thank you for giving me this platform to share my clinical cases, which I've learned and achieved through this course. A patient named Landu Chungla, she walked into my clinic, 56 years old female. She had a complaint of crown fallen off. Then she said this crown was done 1 year back. And on examination, the crown 3/6, that crown has fallen off. And IUPA was taken. We saw that it was failing endodontic case. So the treatment done was retreatment of the tooth 3/6 and full coverage composite crown for the 3/6. And I called the patient after 2 weeks for follow-up. So when she came for follow-up, I asked about the cases. She said everything is good. She's fine with it. She's happy with it. Then I took the opportunity to raise the pitch for the FMR. I asked, ma'am, what do you think? Do you have any concern for your smile? Your teeth are getting shorter and there's cracked lines and discoloration. Then she said, yeah, she feel embarrassed and not comfortable to smile in public. So she showed me the interest. So, but then she said, doctor, but I don't want to go for any extensive crown cutting treatment or that big budget. So I said, yeah, sure, we can go ahead. Firstly, we will do a test, ODBA test, and then we'll see how many teeth are involved to be done, and then later you can take the call regarding the materials to be used then according to your budget. Then she agreed. So on comprehensive examination, extraoral, DMG, no clicking, no pain, muscles, no sign of tenderness. Intraoral examination, we see that 36 has recently, just 2 weeks back, we have done the treatment, and we see the 2 upper central incisor and 2 lower central incisor on edge to edge bite, tooth wears and facets on almost all the teeth, and we see the cracked lines there, and there's a PFM crown in 3/5, diastema between 16 and 17, and the missing 18, and of course stained in calculus. We took the pre-treatment record, that is deprogrammar, Facebook, CR bite after deprogramming, then first point of contact in the mouth, and articulated model, cast model, and master model and mock-up model. So we went for pre-treatment photographic records. This is on smile, then right and left profile. This is how she looks like in intraoral MIP. You can see that the 2 upper and lower incisors are edge to edge bite and a lot of cracks there. And this is on the right and the left side and MIP. This is on lateral excursion. You see that there's on the working side and non-working side, there is a pathologic group guidance, pathologic group guidance. And on protrusive, you see that the canine is guiding it. And this is the 12 o'clock and interior coupling, which is like edge to edge bite. This is the occlusal service. So I went for the comprehensive treatment planning on semi-adjustable articulator. I found that the first point contact is same as in the mouth. So we went with the equilibration. So, okay. Lab instructions, vertical dimension is 0, and upper incisal edge, I asked the lab to increase 1 to 1.5 on 3 to 3 upper 3 to right to left. And centric stop interior, I asked the lower interior contact on the upper cingulum, and posterior increase the occlusal surface on 35, 36, and 45 and 46. And regarding the angle of interior guidance, enough guidance to disocclude. And the aesthetic occlusal plane, the buccal cast of the premolar and molar, confirmed to the line coming from the interior smile line. So this is what I got, the wax up from the lab, the upper canine to canine, and the lower 3, 5, 3, 6, and 4, 5, 4, 6. And I met the putty index there. And the patient wanted to go ahead only with the composites, like she said earlier, with the minimal budget. So this is the equilibration cheek, and we went ahead with equilibration in the mouth. And we also see that the dots at the back and lines in the front. And this is after the composite restoration done. And this is what it looks like after the treatment. In CR equal to MIP, and this is on little mouth opening. And this is on working side and non-working side. Now we say that there's a canine guided occlusion on both the right and the left. This is on protrusive. We see that the 2 lateral central incisors are guiding it. And on intercoupling, we see the overchat and overbite. So this is how it looks like post-op, the smile and the right and the left profile. And this is how it was before, if you can appreciate the edge-to-edge bite and the cracked lines and all. Now we see much better improved. And this is the smile we had before and after. Thank you so much. Thank you to our mentors. And I'm here, through this course, I could exactly learn what occlusion is. And I always desired to do comprehensive examination and comprehensive treatment planning on my patient. And today, I can do that, this as a complete dentistry, as the real dentistry. I just want to conclude with 2 points where I am today, the reasons where I am today. Firstly, it is the mentors who they have guided me, trained me, helped me, and ingrained in me to come out of my comfort zone. And secondly, they have made me understand and realize that being done is better than being perfect. Perfectionism kills. Thank you.
Thank you. Wonderful, wonderful, Demjan. So happy for you, man. Come. Great. I can call, she is like very calm, composed, but yet very, very powerful. In simple 2 lines, if I have to explain Ruchi Lohia, after the first hands-on, she was literally upset, to be frank. Is this course for me? Will I be able to do it? So is it like, some people are so thorough, they are understanding everything, but I'm not able to follow. That was a real thought process. But after that, she made it a point, she wanted to be in the journey, and she fought very, very, very hard. She is one of the most consistent person who has done all the exercises. First, she didn't say she is going to present. Then all her colleagues and mentees here, they wanted her to present by showing the case. It's because of your, really, okay, 0 to this level. Okay, I still remember one case what sir has helped her through phone. Still I remember the case. And she followed it phenomenally, and she gave a beautiful result on a splint. That is something amazing. Thank you for coming here. Rock the stage.
Hello, I am Dr. Ruchi from Kolkata, and this is my first ODD case. So the chief complaint of the patient was that he wanted full mouth rehabilitation. He was a chronic pranparag chewer, past dental history, has undergone few root canal treatments, medical history, controlled hypertension. TMJ symptoms were not there, but signs of occlusal disease was seen. No muscle symptoms was there, but signs of signs were seen. Teeth and supporting structure, lot of tooth had root canal treatment done. There was generalized bone loss, functional cusp wear, and dentinal exposure, occlusal rimples. Right side, more wear was there. Patient was willing for treatment, patient was willing for crown and bridge, and patient was not willing for replacement of missing teeth with implant. Patient is a bruxer as well as a vertical clencher, more on the right side. This is OPG X-ray with lot of root canals, lateral ceph, upper and lower PVS impression was done. These are the models, right, left, and the intraoral photographs. In MIP, teeth apart, functional right, all teeth were involved, non-functional right, functional left, group function involving all the teeth, non-functional left, protrusive. Protrusive right, protrusive left. I started with the ODBA test. Facebook record was done, kiosk tree program was given, CR bite was done, first point contact was matched, and then upper and lower cast were articulated with Facebook and lower with the CR. Treatment planning was done on equilibration sheet and it was a full additive case. Lab instructions were sent to the lab and criteria for deciding vertical was anterior coupling, aesthetic, phonetics, choice of material, minimally invasive and restorative convenience. This was a VAXA which I got from the lab, occlusal MIP. -1 was the pin reading and VAXA was done. This is right, left. Lab putty index was made from the VAXA. Following PAP rule, case was done. According to PAP rule, first posteriors are prepped and temporaries are placed, then anteriors are prepped. During finalization stage, anteriors, which is our front wheel, is fixed first, then posteriors are placed. So these are the way I did. First appointment, I prepped the posteriors upper and placed the temporaries. Second appointment, I prepped the lower posteriors, placed the temporaries. Third appointment, upper and lower anteriors were prepped and temporaries were placed. Static and dynamic adjustments were done in temporary and patient was recalled after 3 weeks. Patient was comfortable, no problem in chewing food and was even having badams. So these are the temporaries in the cast. This is in the mouth. I tried to do some adjustments and following PAP rule, I completed the case. First the anteriors were placed, a BIS trial. I did the adjustments, sent to the lab for the final. The finals were placed and these are BIS trial with temporaries. And this is the permanent in upper and lower. And this is with static and functional adjustments. These are the before and after pics, MIP, teeth apart, right, left, occlusal upper, lower, protrusion, functional left, right, overjet, overbite, and these are the extraoral photos of the patient. Time to be happy. Follow-up was done once in 6 months. S6 overlay was given for night wear. I would like to thank you, sir, ma'am, and definitely my friends there who encouraged me to do the presentation. Definitely this is not my best work, but I assure you, picture of you back here.
Great, wonderful. I say no, she's soft, but very powerful. Wonderful. Thank you for coming. Next, these people always travel as gang. Okay? And they want the seat as a gang. They want to join POS as a gang. They want to travel as a gang. And he's giving me a hint. You didn't say anything about the gang leader. By this time, you know who is the gang leader, right? He is the man. And because of ODD, we started with the protocol that we have to admit only 10 to 12 students. Okay? There was one group which broke the protocol, who breached our protocol is this particular batch. Because of them, we are forced to increase the seats from 12 to 16. And that became almost like 3, 4, 5 batches. Now in 6th batch, we restored our normal protocol back. Okay. Thank you, sir. Thank you, Nihar, sir. Your time. Yeah.
Yes. Good morning, everyone.
Mike.
Relax. Don't drag from here.
Good morning, everyone.
I am the victim, sir.
Thank you, Vasant sir, Mala ma'am, Ramesh sir, for giving me this opportunity. Uh, okay. Thank you. Thank you, sir, for giving me this opportunity. I would like to start with this because this is the best motivation I can get, that you need to do your duties and do your karmas. It will come back to you no matter what. So this is my first case, a female patient, age 60 years. Complaint was sensitivity and pain in the teeth, and her husband's complaint was he's slow chewer, slow eater, because he said
Only
even,
one
huh?
from husband?
He finished his lunch and dinner, she's still eating, she's still eating. So,
Peculiar teeth complaint.
yes, yes.
And only one, sir.
So, she has medical history, diabetes only, and there is no TMJ significant finding and no muscle findings. This is her intraoral photographs, upper occlusal, and as sir said, open your occlusal eyes. Everything we can see, atresion, abrasion. So, this is.
You know what is the science? Smart man.
So, this is everything. This is right side MIP. This is protrusive, right. This is MIP left. This is with or without smiling. This is pre-op records, Facebook record, and then upper articulation. This is DASA, anterior deprogrammer, CR bite record, and this is mounted articulated model, and this is the treatment planning and mind mapping. This is totally additive case, so no equilibration was done, and we have planned fixed processes in first quadrant 5, 6, 7, and in fourth quadrant 6, 7 was CPD. So criteria for fixing the treatment vertical is anterior coupling, overjet overbite, guidance in dynamic occlusion, restorative convenience, minimally invasive, aesthetic and phonetics. And then we have given the lab instruction. This is the backs up we received from the lab, and we have checked on the articulator for the static contacts. This is mock-up in the mouth, right side canine guidance and left side canine guidance and protrusive guidance. This is putty index. Then we have started with the clinical steps. We have first prepared the posterior teeth. I don't have intraoperative pictures, so I am just putting the impression. This is upper anterior impression, and that's upper posterior prep. We have asked for the BIS trial for the posteriors and CPD before wax up for trial. This is anterior, upper and lower. So these are the dots and lines. So these are dots we are able to achieve in the static contact. And this is MIP. This is the right side MIP. This is canine guidance right side. This is protrusion. This is left side MIP. Left side canine guidance, but it was more of a group function involving canine and premolar. This is protrusion. This is overjet overbite. Upper aesthetic, lower aesthetic. And these are the dynamics we are able to achieve. Left side group function involving canine and premolar, and right side canine guidance. This is lower, and this is what we have achieved. So you can see before and after pictures. Right side MIP, left side MIP. This is front, and this is with and without smiling. So that's it, and we have given her DASA post-operative for protecting the system, and we will have follow-up after 4 to 6 months to check the dynamic and occlusal context. Thank you. Thank you, everyone. Thank you, sir. Thank you, sir. This is my first case presentation ever at any stage, so I am really thankful to Vasant sir.
First time on stage after reception. Very good.
First time ever, sir. So thank you, Vasant Dental Academy, everyone. Ronak sir for pushing me
You are
to
forced
join.
to say this, no?
Yes.
What to do?
And also Dr. Dharmendra for helping me with this case.
Okay.
And thank you everyone.
The best part is they are like good friends. They complement each other. They work together, and they pull their legs together. So everything happens among them. I'm proud of your friendship here. Great. Thank you for the present. It's a wonderful case. With a cast partial, that too without attending our cast partial course, getting a dot on the teeth, no, then we should really appreciate. That means you understood the concept of occlusion clearly. We are very happy about it. Okay. Next comes another star. How many ODBA tests you have done, sir? 25. 25 is the number. Almost he sent only some number around 40, 45 is the total case. Totally, yes, what he has said. 25 ODBA test. The numbers, his practice has changed. Welcome, Dr. Kuntal, sir, for the presentation, please.
Hello, everyone, ODD buddies. More than the case, I would like to share my emotion with the occlusion journey. First of all, my gratitude to my spiritual guru, Rishi Prabhakarji, and Vasant sir and Ramesh sir. Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Parabrahma, Tasmai Si Guruve Namaha. So, teacher is like a god. And that I have seen here in mentors. My other gratitude to my wife who pushed me to the occlusion journey. I'll briefly tell. It was 9th February 2024. Sir came to IDA Baroda branch. Yes. I have 9th and 10th February.
He came to Baroda on 8th.
Yeah. So I enrolled for the course. 9th, sir was teaching about condyle in the hall, and in the evening my wife fractured her radial condyle. Next day we have an appointment for orthopedic surgeon at 11 o'clock. Sir's Sunday morning session started at 9 o'clock. She pushed me, you have passion for this thing, you go, come back in between. So I went for the session, come back in between about 11:30, 12, and we consulted, everything was okay. So I again went back to your course, and immediately I told sir that if you are conducting course, I'll attend. Also gratitude to my daughter who is having her parent orientation today. It is her first day of the college. I was supposed to be there, and she said, you have passion for this, you go. And my son at night 1:30, yesterday 1:30, I just came, I landed here and saw the message that we have to put this symbol. So I called up at 1:30, please add this thing, I don't have laptop here. So he did it within 15 minutes and I could present here. So thank you everyone. Also, apart from the case, I want to share my journey of ODD. Occlusion journey started in year 2000. I was just a lecturer in KM Shah Dental College, and I was teaching dental anatomy histology. So this occlusion subject fascinated me. So in the library I used to read Peter Dawson, but the language is very difficult. But they allow only to read in the library only. So I told one of my friend in Ahmedabad College, you please get one Xerox copy for me. So I got the Xerox copy of Peter Dawson. But unfortunately, then in the practice, I could not advance that occlusion journey. And the language was very difficult. It is said in our Shastra that Guru Vina Gnan possible nathi. So I got Guru in year 24 only, 2024. Then the journey started. So this is case, I just wanted to emphasize, I tried to follow all the steps sir told. So this is a full mouth rehab case with equilibrium, canine rise, restoration in the back side, upper back side with the implant, crowns and composites. Patient basically came with the The chief complaint was to restoration of the back teeth only. There was no symptoms or signs in the TMJ, mild symptoms in the muscle, that is lateral pterygoid was little bit tender. Teeth, there were signs and symptoms was present. So back teeth were missing, and some dental work done before also by other dentist. So this is his pre-operative photograph, ODBA test. This is excursion before treatment, facial photographs, face bow, first point contact match in the articulation. So I proceeded with the planning, and in planning, since I have planned and it was patient's request also to go with the minimum. So I did not restore anterior teeth. I managed with the composite in the canine and back side. Yeah. Here canine rise I have done 2-7 and 3-7. I did root canal and composite onlay. And upper back side I put implant, and third quadrant there was a bridge. This is the wax up photograph. I gave temporary and did equilibrium in the temporary and got dots and lines in the temporaries. This lab instruction form. This BIS trial, final one, dots and lines in the final restoration. This is after treatment photos, in the excursion, facial photographs. The last step, what patients touched is whatever the process we followed, and he has visited lot of dentists before that also, but this detailed process we followed. Even I saw him the after treatment models, after treatment photographs, he was very happy, and this is the happy face and my team who helps me in clinical side and laboratory side. Thank you. One point I missed, that is in the fourth quadrant. I planned that I will this 4-6 I will replace the crown, but I missed to took the X-ray since it was done by the other dentist and there was only one root. So and 4-5 was also supra-erupted. So I removed the distal root and gave half cantilever bridge, distal side, not allowed, but there was no choice at that time. So I have included in ODBA test full mouth, either OPG or IOPA. So this was the reflection after treatment. Thank you.
Thank you, sir. That shows he is a very phenomenal man in submitting the exercise. You can see his photographs, right? He started correct, that's why he is here. That's why we have been telling you for the past 1.5 years, more than 1.5 years. Every time, that was the first exercise, first initial 6 to 7 exercise, photography was the first. I know people here who have done more cases, but no photos, no documentation. Don't ever do that mistake again. You will feel bad. Okay, always document. Documentation was amazing, sir. Thank you. Thank you. Okay, almost like 110 people. There was one person. This is how it happens. No, we go to many places, we talk something, but one person getting inspired. It was not registered in my mind also among that 110 people, to be frank. Okay, so thank you, sir. Thank you for this presentation. Next comes, many people are presenting for the first time, but I don't feel like they are doing it for the first time. Yes, right? That's what I feel. There is no, we came across a lot of that fear and all, right? So Dr. Sweta, she came with the articulator to the airport. In a coffee shop, we have been discussing a case before I catch the flight. So that was the level of anxiety she had when she started an FMR. From there, I am eager to see what she has done. Thank you. You can start. Wait.
Good morning, everyone. It's an honor to stand here today in front of such experienced clinicians and mentors. Looking at Dr. Vasant sir's presentation, especially the module 16, the 8 cases, I was very inspired. Like the beautiful integration of limited crowns, cast partial denture, orthodontics, and and very limited bridges. So it was not about 28 crowns. So I'm not a person of 28 crowns. And I was always looking for an answer. Like whichever FMR courses I have done before this, it was all about 28 crowns. I would see the pictures and I was like, this good tooth structure. Why are they cutting it? I was never convinced. So this is something what I learned the most from this course. So yeah, so this was truly inspiring. And saving what is in the mouth is equally important or as important as what you add. So, this is something which I loved the most about this course. So, one second. Presenting a simple case. Okay, so this is how this patient walked in. His only complaint was that the food is getting stuck with his forceps and he has wear with respect to that tooth. So he's like, I want to restore this tooth. So he had come to me almost 18 months ago. I had just started ODD, I had just enrolled for it. So I knew I would have a better answer. So I told him, you close. When, in occlusion, I told him, look, there is no space over there to restore this tooth. Give me some time. I will be able to do this in a better way for you. Rather than right now me, trimming the tooth either with restoring it with a crown or with a filling. In MIP, this will not happen. So somehow he got convinced and he's like, okay. So he's like, okay, we'll do it after some time. He was fine with it. I was like, okay, good. So then 3-4 months ago, he came back and I told him, okay, fine, let's do it. I told him, I need to take all the records, I need to take all the photos, you'll have to be you'll have to be okay with that. So he's like, okay. So we took all his records, all his photos, the MIP, the protrusion, we see how there is so many interference on both the side, the right side, the left side. So he was like, fine, then I took his impressions. I gave him an overlay type of deprogrammer to wear in the night. I told him, wear it the whole night, wear it next day morning after breakfast. When he came, I changed it to a deprogrammer and I took a CR bite, articulated and everything, and then I had a treatment plan. So his only problem was that he had lost the enamel and the dentine was exposed with respect to forceps. He understands that he was grinding. He had no muscle or TMJ complaints, no pockets, no class 5s, no class 2s. So I was like, fine, I have mounted everything. And my plan is to just, equilibrate some of your teeth. Even the bridge that he had on the left side was good. So both the teeth were fine. There was no decay below the bridge. The root canal was fine. So I just didn't want to change it. So I was like, I will first do it everything on the model. And let me give you a plan. So I did that. And I told him all that I want to do is equilibrate your few teeth, okay, and just restore all the lower teeth. So that's what I did. I equilibrated on the model and everything. My plan was to do the composite build-up on the model. I made a putty index out of it. I transferred it in the patient's mouth, equilibrated in the patient's mouth, made a new putty index, and then used that to restore all the lower teeth. So, as I spoke, put the putty index, with the help of putty index and ProTemp, I made his temporaries, equilibrated it, and made a new putty index out of this, and used that to restore his lower teeth. So, this is how I restored his lower teeth. Up, if you see, are the pre-op photos and the post-op photos. So, all his lower anteriors restored. You see on the right side, his molar restored. On the, the lower, all the lower teeth were restored compared to what he came with. And basically, the restoration was from 4-6 to 3-4. all of them restored. I did not touch the upper teeth because I didn't feel the damage was too much. So I saw this in a lot of cases which sir had represented, that like very little exposure, just let it be. You've put the patient on guard, you have restored the front wheel of the auto, you have given them a guard, it will stay. So this is something which I really loved, and I've done a lot of such kind of cases, and this is one of them. All the dots and lines in places. So yeah, this is something which I learned, and this is something which I think I see routinely with a lot of my patients. So, and when sir said he's made us do so many, the time is over? I have. So so the best thing about the exercises according to me is, like, when he said you have to do this exercise 5 times, you have to do it 10 times, so many times doing these mountings, the laziness and the comfort, you got out of that comfort zone, and now doing mounting does not feel hectic. Taking a CR bite does not feel hectic. It's just become so routine. And even your assistants are so well trained कि like, suppose ma'am आपने photo नहीं लिया, oh yeah, I was like, okay, photo भी लेना है. So that is amazing, like, to get us out of that comfort zone, and like, like training. And he kept saying, train your assistants. So yeah, I have been working on that. And another thing, what Dr. Ramesh says, let the patient take the ownership of his problem. That is again one thing which has stayed with me. So now I have become confident telling people, okay, if you're not going to wear the guard, I'm okay to not do your case. Because if your natural teeth can fracture, my composite may also fracture, or your ceramic will also fracture. And I think patient can also gauge the confidence, like, and because of this journey, like now we have few documented cases, and now I've seen now they're lasting, it's been 6 months, 8 months. So the confidence that which I have started talking has really helped me a lot. So yeah, so thank you all the 4 mentors, sir, ma'am, for this, guidance. And, I think our cases are a proof and a testament to, like, their mentorship and to minimally invasive dentistry.
Thank you. That was a great compliment, Sweta. From that confused face in the airport to this face, I see a lot of change. She is so happy. Thank you for that wonderful presentation. Wonderful.